Hi, and welcome back to the Pro-PA Podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're talking about myocarditis, a condition that can range from asymptomatic to life-threatening heart failure. Whether you're preparing for the PANCE or PANRE or want to sharpen your clinical knowledge, this episode will walk you through what myocarditis is, how to recognize it, diagnose, and manage it effectively. Let's jump right in. Beginning with some basic pathophysiology, myocarditis is inflammation of the heart muscle, which is the myocardium. It can be acute or chronic and is often caused by viral infections, like Coxsackie virus, but it can also be due to autoimmune conditions, drugs, bacterial infections, and environmental causes like exposure to carbon monoxide, black widow venom, or snake bites. The inflammation damages heart cells, which can lead to arrhythmias, dilated cardiomyopathy, heart failure, and even sudden cardiac death. Who does myocarditis affect? Myocarditis doesn't discriminate, but it's more common in younger adults, particularly men, and often follows a viral illness. The clinical presentation can vary. The range is from absent or minimal symptoms to chest pain, heart failure, cardiogenic shock, arrhythmias, and sudden cardiac death. Symptoms may include fever, rash, chest pain, shortness of breath, orthopnea, abdominal pain, fatigue and exercise intolerance, syncope, and palpitations. On physical exam, you may see signs of heart failure, like peripheral edema, jugular venous distension, hepatomegaly, S3 or S4 gallops, rales on lung auscultation, arrhythmias, and a pericardial friction rub if there's an associated pericarditis. Remember, myocarditis should be in your differential for any young patient with unexplained cardiac symptoms after a viral illness. Regarding diagnosis, the gold standard for myocarditis is an endomyocardial biopsy. This will definitively diagnose myocarditis. However, it is rarely needed. Instead, we rely on support from clinical findings, laboratory evaluation, and cardiac imaging. Initial labs usually include a CVC with differential, complete metabolic panel, erythrocyte sedimentation rate, C-reactive protein, cardiac biomarkers, and a B natriuretic peptide. You may find elevation in the ESR and CRP, but this finding is nonspecific. The troponin is commonly elevated, but make note that absence of elevation does not exclude the diagnosis, and the B natriuretic peptide may also be elevated. An electrocardiogram is not required to diagnose myocarditis, but is generally obtained to exclude alternate causes of cardiac symptoms such as ischemia, to evaluate for arrhythmias, and to identify features that may suggest certain causes of myocarditis. And the ECG may show nonspecific ST changes, ventricular arrhythmias, or atrial fibrillation. You'll also want to order a chest X-ray. The heart size may vary from normal to enlarged, and with or without pulmonary vascular congestion and pleural effusions. Now, as far as your imaging, you want to order an echocardiogram to evaluate regional and global ventricular function, valvular function, and other potential causes of cardiac dysfunction. This may be normal in early or mild disease. And a cardiac MRI. This is indicated in patients with clinically suspected myocarditis, an accurate non-invasive tool used to detect myocardial inflammation and replacement fibrosis. Now, lastly, although generally not required, coronary angiography is indicated in selected patients with clinical presentation indistinguishable from an acute coronary syndrome, lifestyle-limiting coronary disease despite medical therapy, or high-risk features for ischemic heart disease on non-invasive testing. Now, let's move on to the management. The management depends on the severity of the disease. This includes general measures, including heart failure therapy, treatment of arrhythmias, and management of the underlying etiology. Potential options for patients with refractory heart failure despite optimum medical therapy include mechanical circulatory support, such as with a ventricular assist device, and cardiac transplantation. Things to avoid for these patients are nonsteroidal anti-inflammatory drugs, which are your NSAIDs, heavy alcohol consumption, and exercise. If you suspect myocarditis, refer immediately to cardiology. These patients can deteriorate quickly, and early intervention is key. They will need routine follow-up, including serial echocardiography. Now, preventing myocarditis is tough, but some key strategies include managing autoimmune conditions, avoiding cardiotoxic agents when possible, such as amphetamines and cocaine, and prevent viral infections with regular recommended vaccinations. Here are some clinical pearls. Number 1. Always suspect myocarditis in young patients with new onset heart symptoms after a viral illness. Number 2. Cardiac MRI is the best non-invasive tool to confirm the diagnosis. Number 3. Avoid NSAIDs. These can worsen inflammation. Number 4. Myocarditis can progress to dilated cardiomyopathy and heart failure. And number 5. Early referral to cardiology is crucial for proper management. The challenge is that myocarditis can look like a bad flu or even a mild chest cold in the beginning. Some patients recover fully, while others develop chronic heart failure or arrhythmias. The key is recognizing it early. All right, let's practice some questions. Question 1. A 25-year-old man presents with chest pain, fatigue, and palpitations for 1 week. He had a flu-like illness 2 weeks ago. Patient has no known cardiovascular risk factors. Electrocardiogram shows nonspecific ST changes, troponins are mildly elevated, and echocardiogram shows global hypokinesis with an ejection fraction of 45%. Which of the following is the most likely diagnosis? Is it A, acute coronary syndrome, B, myocarditis, C, pericarditis, or D, pulmonary embolism? I'll give you a couple of seconds. If you chose B, myocarditis, you are correct. A young patient with recent viral illness, chest pain, elevated troponins, and decreased ejection fraction on echo is classic for myocarditis. Acute coronary syndrome is less likely due to the patient's age and lack of risk factors. Question 2. A 30-year-old woman presents with fatigue, palpitations, and exertional dyspnea. She had a viral illness 2 weeks ago. ECG is normal, but cardiac MRI shows myocardial inflammation. Which of the following is the best next step? Is it A, start ibuprofen and send home, B, admit for cardiac monitoring and start heart failure therapy, C, schedule a cardiology outpatient follow-up in 2 months, or D, order cardiac catheterization? If you chose B, admit for cardiac monitoring and start heart failure therapy, you are correct. Myocarditis can rapidly deteriorate, and early cardiology involvement is crucial. NSAIDs can worsen myocarditis, so they should be avoided, and a delayed follow-up could miss worsening symptoms. Great job! That wraps up our discussion on myocarditis. This is one of those conditions that every clinician needs to have on their radar, especially in younger patients with viral illnesses. Recognizing it early can be life-saving. If you enjoyed this episode, be sure to subscribe and leave a review. Stay tuned for our next cardiovascular episode. And, as always, this is the Pro-PA Podcast, where future pros in medicine are made. See you next time.